open this with Google Slides because I think it'll just project better. So just give me a minute to open that.
Hi, Dr. Brill.
Oh, hi. You guys are from the conference room?
Yes, it's Ron.
Hi, how are you?
Good.
Okay. All righty, so now I should be able to forward them. So we're going to be talking about, why you might use medication like this in teen girls. We're going to talk about different ways that birth control pills are packaged in terms of the dosing and how delivery systems of medications, why you may want to be watchful. I came in obviously on the tail end of your morning report, but it looked like you were talking about a patient who had a stroke, and I don't know the story because I didn't hear the case, but unfortunately birth control pills are, can be risky in patients who are prone to stroke. So that's something that, we'll kind of talk about today. I don't expect that you guys are going to go, oh, now I can go ahead and prescribe this, but you might be a little bit more comfortable over time with it. And I'm going to focus on both birth control pills and long-acting reversible contraceptive options. Okay, so I'm going to do just by, I guess you could just do this by a show of hands in the chat, a thumbs up or thumbs down. True or false, the dose of estrogen and oral contraceptives has remained constant over time. Is that true or false? What do you guys think? I don't know if I could actually see your.
False.
False.
Okay, yeah, you can just tell me. So this is false. The dose has actually changed quite a bit, and in fact, it's gotten much less. I just had a clinical scenario the other day where we were talking about a birth control pill for a patient, this was actually yesterday, and the mother said, oh, I took pills and I took something, it was called Orthonovum 777, which was a pill that was very popular in like the mid to late 70s. And I blew up and I gained weight, and, the dose of today's pills are about half that. And certainly the dose from original pills is quite a bit lower, as we'll see. Sorry, I'm having trouble. Okay, migraine with aura is an absolute contraindication to using estrogen-containing pills. False.
True.
Put it in the chat. Okay, this is actually true. I don't know if anybody's putting anything in here. No. So I don't know if anybody is aware of this, but migraine with aura, which is a very typical, like a stereotypic type of migraine, where patients get a specific image or zigzag lights prior to getting a bad headache. That's actually a contraindication because it does lead to a higher risk of stroke, as you had discussed before. And lastly, extended cycling pills may help in controlling menstrual hygiene and dysmenorrhea in selected patients. What do you guys think? Do you think that's true? You think you shouldn't use that? I see a thumbs up over in the conference room.
Yes.
Anybody else?
True, I think.
Sounds good. Okay, so this is true also. And as we'll talk about, I have, particularly when I talk about menstrual hygiene, I have kind of a subset of patients with autism, severe seizures, other developmental disabilities, where when these girls get their periods and they mature enough to get their periods, can be very challenging. So these are situations where you may want to use a pill where patients don't get their period every month, and that's referred to as a standard cycling pill. Okay, so just going to talk a little bit about the history of pills. I love medical history. I love seeing how things have changed over time. So hormonal contraception has really evolved over time. And we know that things really started with a birth control clinic in the US in Brooklyn. Margaret Sanger opened this in 1914 to 21, which was a forerunner of Planned Parenthood. I'm not sure exactly what they did there or what they gave women, but maybe they taught them a little bit more about fertility and family planning. I'm not sure. In the 50s, chemists in Mexico City created a progesterone pill from yams. And then there was independent work done in the US along with a gynecologist and endocrinologist. And this is actually funded by McCormick Spices. And they did trials on progesterone pills to see if they would work to prevent pregnancy. By 1960, the FDA approved the first pill for contraceptive use. The dose was mestranol. That was 150 micrograms and that's a variant of estrogen, about the same as estrogen, though. That's about 6 or 7 times the dose of what's in a pill today. The progesterone was called norethindrel. Can you guys hear me okay? I know I have some noise in the background. Can you hear me okay? Just yes or no?
We can hear you.
We can
Sorry,
hear
my
you.
house is getting clean today. So by 65, over 6 million women were using the pill, which was the most popular method in the US at that time. It really changed society. Many people attribute the so-called sexual revolution to the availability of birth control pills, which essentially led to a fairly dramatic increase in premarital sex. And it really was often ascribed to medication that women were able to control their fertility for the first time. However, as more women took the pill, there were side effects, and there were things that happened to women that people recognized were due to probably the dose of the medicine. These were things like blood clots, heart attack, stroke, depression, gaining weight, and loss of sex drive. And there was quite a bit of negative press around the pill in the 70s. And I actually remember this as a teen, hearing that this was dangerous and this was not something that kids should take ever. So sales actually went down about 20% by the late 70s because there was so much publicity about the health risks. And there wasn't so much thought about the benefits, it was just the risks. That led the pharmaceutical companies, please go upstairs. No, aquí. Por favor, atrás. So the lower dose pills came on the market because there was a sense of, well, if this medicine is effective, maybe a lower dose will still be effective with fewer side effects. And the dose dropped rather than the 100 to 150 micrograms of estrogen. Now we were seeing pills in the 35 to 50 range. And the Orthonovum 777 that mom had taken earlier, that was a 35 microgram pill, which was considered a very low dose pill at that time. Most were 50. So by the late 80s, the high dose pills were taken off the market. Even today, the highest dose pill you can get is a 50 microgram pill. And I prescribe that very rarely. And then we start to see a shift in that there was health benefits to the medicine. Not just that there was contraception, but they saw that there was a decreased risk of certain cancers, particularly ovarian and uterine cancers or endometrial cancer. The pills helped women who were having heavy periods and prevented anemia, and even seemed to be protective against PID, although that's been debated since then. By the late 90s, the pharmaceutical companies applied for non-contraceptive indications for birth control pills. And the first one was Ortho. So the brand orthotricycline was actually FDA approved for acne. And that was a real game changer because acne affects a lot of people. And by having a medicine to be able to treat the acne, that was really a tremendous boon for the pharmaceutical industry and for patients who had another way of treating this common health issue. By early 2000s, the FDA approved Seasonal. That was the first extended cycling pill, which basically allowed women to take 3 months of active hormones, and then a placebo week, only getting 4 periods a year. And that was a tremendous change. Again, that became very useful for people who really had difficulty tolerating their periods. For every lash, there's a backlash. And a lot of the newer medicines, they were starting to study what the risk of blood clots and strokes was. And they found that Yasmin and Yaz, which was a new pill in the late 2008, 2009, came out that there was a slightly higher uptick in blood clots and strokes. These pills had a specific progesterone called drospirenone, which they thought had a slightly higher risk. And these were, Yasmin and Yaz were aggressively marketed. Every OB-GYN's office had samples of them. So I think the later studies revealed that there was bias against them because they were prescribed so often that they were statistically, a very high chance of somebody getting that medicine if they went to their doctor because it was sitting in every cabinet. But most individuals still think there is a slightly higher risk in drospirenone formulations. The dose of the modern pills is now somewhere between 20 and 30 micrograms of estrogen a pill, and there is even a 10 microgram available, which I use occasionally. So the dose has gone from 150 to 10 in, about 40 years. And that's something to really keep in mind when you hear about people being scared about the dose of it. So here's the original birth control pill. It was 1958, and you can see the mestranol, the 0.15, and the norethindrol, 9.85. So it was called a 10 milligram dose because it added up these two. This is in 1958. So it didn't come in a pack. It came just in a little bottle like this. And this is the 10 microgram pill. This is low estrogen, has 10 micrograms of estrogen a pill. Okay, there's an explosion of brands and doses. Every time I think I know the brands, a new generic comes out. I find out a patient's taking some other name pill, and it turns out to be a generic for some of the pills that I know. And really, there's probably about 15 formulations of birth control, but there's maybe 100 brands, and many of them are branded products of the same thing. So why might a teenager take birth control pills? One of the main indications that I use medications all the time is menstrual cramps or dysmenorrhea. We know that patients who have painful periods really suffer, have decreased quality of life in a lot of studies, and the birth control pills do relieve dysmenorrhea fairly effectively. They create a much thinner endometrial lining, and they create anovulatory cycles, which is one of the ways that birth control pills work for birth control. But anovulatory cycles tend to have much less dysmenorrhea. I think we've discussed this in some of our talks, but generally ovulatory cycles allow for a higher production of prostaglandins that lead to menstrual cramps. Crazy dysfunctional uterine bleeding is another big indication. Basically, by controlling by using hormonal control of menstruation, we can prevent a lot of the heavy bleeding and poor quality of life that can involve, as well as prevention of anemia. Acne, as I mentioned, is a tremendous benefit for a lot of patients. Many patients who I put on birth control do not end up needing isotretinoin or Accutane for their acne, even if it's fairly severe or cystic. Menstrual migraines, individuals who get terrible migraines around their periods often will find relief from the pill. And finally, PMS or PMDD, which is premenstrual dysphoric disorder, is often amenable. Some of the pills do have the FDA indication for PMS. Not a lot of them, but most of them will work to some degree because it prevents the hormonal swings that cause the affective symptoms of PMS. So other reasons why we might prescribe birth control might be PCOS. And I think we've talked about, working up of amenorrhea and PCOS in some detail. Ovarian failure, individuals who just do not have ovarian function. I actually have a very interesting patient in my practice I saw the other day. She actually has had an ectopic pituitary and was found to be in, I guess, secondary ovarian failure because she had no production of FSH and LH, so her ovaries were not getting any signal from the pituitary, and therefore she made very little estrogen, never got really much puberty, never got a period. So she was treated with estrogen, and then ultimately was using birth control pills to regulate, to give her cycles. Turner syndrome is is a condition, as you know, where there's essentially streak gonads or ovarian failure. Birth control pills just make kids feel like everybody else. It's just an easy way of delivering the estrogen in these individuals. And finally, girls with developmental delay. I saw a 10-year-old yesterday with horrendous autistic behavior. I mean, she was running around the room, tearing up the paper, throwing food, to have this girl get a period and be moody would be very challenging. So I actually put her on progestin-only medication. Okay, so, if you talk to patients, you'll hear about how menstrual problems affect quality of life. They actually did a study in Australia on amenorrhea, and girls did have an impact on their quality of life, mostly because they never know when they're getting their period. The periods, if they don't get regular periods, the periods are very heavy. Girls with PCOS often have hirsutism and acne, and it really can affect psychosocial function. So birth control can really help with a lot of these areas. So we know that this medicine provides a great tool for relieving symptoms, but many myths and fears persist among patients, parents, and even us. So this lecture is to try and help you guys understand that, yes, this is not a vitamin. There are risks to everything we do, but there's a lot of benefit as well. So in prescribing pills for teenagers, we want to review a personal and family history. We need to include a blood pressure to make sure that patients are not hypertensive and do a general physical. We don't need to do a pelvic exam on these patients. I do screen for family history of stroke and particularly DVT. I had a patient 2 weeks ago that I had seen for about the second time, really wanted to go on the pill. I think she had heavy periods. And I started asking her a little bit about her health and her family history. And I had gotten a family history when I'd seen her about 6 months before, and it was negative. And I had asked her earlier in the visit, has there been any change in anyone's menstrual, history and anyone's family history? She said no. And then when I started talking about the pill and DVT and pulmonary embolus, she goes, "Oh, my mom had a pulmonary embolus recently." And I was like, okay. And it turned out that the mom was a nurse who worked in a rehab facility, and she had COVID in the spring and never felt her breathing got back to normal, and ultimately ended up having 2 pulmonary emboli that she didn't realize she had, and was getting, anticoagulated at that time. So I felt a little bit uncomfortable to put her on the pill because of a first-degree relative with a thrombus. I consider at least a relative contraindication until you make sure that that patient doesn't have any thrombophilia condition. If patients are sexually active, we do want to recommend a concurrent barrier method, usually condoms. And I usually will assess how motivated a teenager is, how functional they are, whether they've been compliant with medications, and whether they've had any previous experience with the pill before prescribing it. So here's your absolute contraindications. These are WHO guidelines. You cannot prescribe birth control, estrogen in these situations. If a patient had a thrombophlebitis or thromboembolic disorder, if a patient had a stroke, if a patient had breast cancer, jaundice, particularly obstructive jaundice, hepatic adenomas, which are sometimes asymptomatic, but rare in kids, hepatic cancers, pregnancy, 28 days postpartum if they've had a termination of pregnancy, migraine with aura, as we suggested, smokers who are over 35, or uncontrolled blood pressure. I've had a couple of kids with really significant hypertension that I've had to even take off the medicine if they've been on it. Now, these are what we call relative contraindications. This sort of implies that you can consider prescribing, but the question is, do the risks outweigh the benefits? And anyone who's been on the pill, who's had migraines and they've been made worse by the medicine, anyone who's had a family history, and I've talked about this with my patient's mom who had the COVID and the pulmonary emboli, diabetics, anyone with vascular disease particularly, and these are rare in teenagers, high blood pressure, smokers, and this I would include vapors in this, anyone who's vaping, who's exposed themselves to nicotine, you have to be more cautious. Anyone who has biliary tract disease, I had a patient who had autoimmune hepatitis and liver failure. I did not put her on estrogen. Medicines that interfere, and these are usually the anticonvulsants, which is why a lot of patients with seizures don't end up going on estrogen. Rarely rifampin, crucifulvin, although these aren't so commonly prescribed. And even obesity is considered a relative contraindication. You know, if I have a patient with a BMI of 50, I'm not going to be so happy to put them on estrogen. I have, but I'm not necessarily going to want them on it for very long. So what's really the risk of blood clot? And if you're on birth control pill versus not on birth control pill, it's about a 3 to 5-fold difference. And that's true in everybody, but the number is very low. So, you know, if the baseline risk of a teen is 1 in 10 per 100,000, which is about where it is, you're talking about 5 to 50 per 100,000, which is still a low number, but not zero. The actual risk is about 0.05%. And it's very important to screen for family history because you could pick up a factor 5, which I believe is autosomal dominant, if I'm not mistaken. And so that's a fairly common condition, and it's very important to screen for that. There's been intense media scrutiny, particularly for the drospirenone pills and even desogestrel pills. But I think it's important to recognize that that may exaggerate the risk. And the dose is also important. We know that higher dose estrogen pills do cause more risk, so I do tend to avoid them if I think there's any risk factors. So what's actually in the pill? I'm just going to take a swig of my milk here. All pills have estrogen, combination pills, and it's usually in the form of ethinyl estradiol. There's a big range in doses, as we've discussed. The progestin is what's different in pills. The doses differ, and the actual chemical structure of the progestins differ. I usually put them into 3 groups: the estranes, which are norethindrone, ethinyl diacetate. Those are older progestins that have moderate side effects. There's newer progestins that are called gonanes. Those include norgestimate, that's an orthotricycline, levonorgestrel, desogestrel, and they have less side effects, and they also have less androgenic side effects. A lot of the progestins sometimes caused acne and extra hair, and a lot of individuals with PCOS and other androgen conditions don't benefit from those as much. So the newer pills tend to block androgens better. And finally, the newest progestin is drospirenone. That's really an anti-androgenic. It's actually an analog of spironolactone, and that's been very helpful in patients. And that's what's in Yaz and Yasmin. There actually is a progestin-only formulation that just came out too. Okay, so as I said, most pills are 20 to 35 of estrogen. Pills, the progestins can also be think of in terms of generation, you know, what came first. So these are the early progestins, then the middle, second generation, and then the third generation, as you see. On top of the fact that there's different hormones in each pill, there's different dosing regimens. You can have monophasic, where all pills have the same amount of hormone in the pack. You can have phasic pills where the dose will step up or vary in the pack. That's supposed to more mimic the natural cycle, more or less. And then you have extended cycle, and I put a picture of, it's like a clamshell where you can see 3 packs of pills. There's 84 pills in the pack and then 7 placebos. Very useful in bad dysmenorrhea or heavy bleeding. So how do they work? All pills work by suppressing the HPO axis and inhibiting ovulation. If you do blood work on patients who are on the pill, the FSH and L should really be under 1 in active pills. By inhibiting ovulation, as I said, they inhibit prostaglandin formulation and excessive growth of the endometrium. You see less ovarian androgens. You increase your sex hormone bonding globulin in the liver, so you have less free testosterone, leading to less acne and hirsutism. And again, this provides estrogen replacement as well. So they really work in a lot of different health situations. And I'll very often prescribe medicines tailored to the clinical problem. So if patients have heavy periods or dysfunctional uterine bleeding and cramps, I'll use a pill that really opposes the endometrium. And the dose, I'll use a little bit higher dose, like 30 or 35 of estrogen. And I'll use the older progestins for these patients. However, the higher dose pills, you may have breast tenderness or nausea, might have low blood pressure, so you may need to modify the dose or consider the extended cycling doses. PCOS or hyperandrogen states, I'll use low androgenic pills. Third generation progestins like drospirenone and desogestrel are ideal, but they may have a slightly higher risk of DVTs, as we said. Weight gain is usually less, fatigue and depression occasionally with some of these medications. And some of these patients may do better on the extended cycling, the 84 pill packs. Okay, so what do we do about side effects? So we kind of have to figure out what are the side effects and then what pill might help. So most pill users, the most common side effect is breakthrough bleeding, and it's usually because they're not compliant. I'll say, do you take your pill every day? Yes. What time? Well, I take it at 6 during the week, but then I'm out on the weekend, so I'll take it at 10, or sometimes I just want to take it till the next day. And that's very common. They think they're taking a pill every day, but they actually are skipping around. And if they're missing pills, they're definitely more likely to have breakthrough bleeding, particularly in the lower dose pills. If patients are really taking the pills regularly and they're breakthrough bleeding early in the cycle, the estrogen dose is too low, and I'll go up on the dose a little bit. If the breakthrough bleeding is in the latter part of the cycle, then we think the progestin might not be working to oppose the endometrium, and I'll adjust the progestin type. Excess estrogen, usually it's headaches, nausea, vomiting, and breast tenderness. So I'll go down by the dose in that situation. Okay, progestin, if the dose isn't high enough, patients, it won't oppose their endometrium and will increase and change the progestin. I'll go back to an earlier generation pill type. Okay, again, extended cycling, great for menstrual hygiene indications, again, for those disabled kids or autistic patients in particular. Autism people often have PMS, so this also helps with mood changes in behavior. You can see irregular bleeding or spotting on them for a while, but once they continue, if they kind of hang in there and keep going, usually you'll get near amenorrhea with it. Okay, pill doses are very low. And remember that in a regular 21/7 pack, a lot of times if you have 7 days off from the pill, your own hormones will rise up again because the pituitary wakes up after a few days of being off the medicine. And then you'll see the patients make some of their own estrogen, and you'll start to see symptoms of either headaches or bloating on patients who are on daily, monthly pills. So a lot of times, they may need a standard cycling pill. Now, a lot of pills come as 24/4 pills, and those can mitigate some of these symptoms. Okay, so how do we take care of patients who are on the pill? I see patients every 3 months at the beginning till I get the pill right, until I know that they're understanding the importance of compliance. And I check their blood pressure because every now and again, patients' blood pressure may go up on the medicine. I work with them to talk about compliance and how important that is. Once patients are stable, I'll see them every 6 months, but I for sure will not let them go more than a year. I mean, with COVID, some of the patients that I see did go more than a year because they just weren't able to get in. But other than that, I really will see them because personal history. Look at my patient who I saw the other day, all of a sudden her mother had a PE, and that was something that hadn't happened before. So I think it's important to see patients yearly. Okay, just if we're talking just about hormones, it isn't only in a birth control pill. You can give these hormones in other ways. And one of the things that I'll do is use something called a NuvaRing. If patients are having trouble taking a pill every day and they can insert something in the vagina fairly easily, I'll give them something called the ring, which contains ethinyl estradiol and another progestin, and releases this much every day. This is inserted into the vagina for 3 weeks, then taken out for a week to allow for withdrawal bleeding. Most teens can put them in. It may not be appropriate for a 12 or 13-year-old, but an older teen can usually do this. And the side effects are very similar, and the contraindications are all similar to birth control pills. Okay, this is not really what the NuvaRing looks like, but I just thought this was a really funny slide. Okay, this is what it looks like. It fits in the palm of the hand, and it gets inserted to as you see, the back of the vagina, close to, here's the cervix over here. So it really goes into the back of the vagina here. Okay, progestin-only methods. Anyone who's worked with me knows I use these pills a lot. I think they're underused. And right now, they're very useful in patients who can't take estrogen. And a lot of those seizure patients who are on the anticonvulsants often will not do well on estrogen. So the progestin-only pills do work more effective, or better in those patients. This is just norethindrome 0.35. It's the third dose of what's in a birth control pill. Often it's called the mini pill for that reason. You need to give them every day at the same time. These are really less forgiving even than the combination pills in terms of breakthrough. So it's important to take them at the same time. Very often girls will spot or have irregular bleeding, but about half the patients end up with amenorrhea on it, which is most of the parents are thrilled to have amenorrhea, particularly for the menstrual hygiene issues. It doesn't help as much as PCOS, but it's really good also for teens who are like 11 and 12 who just have very heavy periods and you don't want to put them on estrogen yet. You can use progestin-only pills. Depo-Provera I've used in individuals. It's a synthetic progestin. It's a standard dose given every 3 months. This injection will suppress the axis. You thin your endometrium. You actually have a very low estrogen state with Depo-Provera. So the first couple cycles, you'll just have bleeding, but amenorrhea usually follows after a year or so of use, which are about 4 injections. Weight gain is fairly common with this medicine, but it's really good for patients with sickle cell disease, who again are more prone to, God forbid, strokes with estrogen, seizure disorders, estrogen intolerance for other reasons, or sometimes just have kids just go on because they won't want to take a pill every day. Remember that because there's a low estrogen state, it can affect bone density. So I will study bone density in these patients if they've been on it for a while, usually over 2 years. There actually is a black box warning on this with regards to the bone density. Okay, I want to talk a little bit about IUDs. These are IUD cookies. Is it safe? And you know, in years past, IUDs was absolutely not. We never thought about putting an IUD in teenagers. In the last 10 years or so, IUDs have come back and have been felt to be a new option for teens. There's a copper IUD and a levonorgestrel releasing IUDs. There's several different brands on the market now. We know that the IUDs reduce blood loss. You can see amenorrhea in about half the patients, and it does have indication for menorrhagia. ACOG says that they do not increase risk of PID, but of course, you won't want to put it in if a patient has PID or infection. So our kids should be screened before insertion. Okay, finally, Implanon. This is a newer version of the old drug called Norplant. This is a tiny little like match size device. It's inserted in the fleshy part of the upper arm, and it contains etonorgestrel. It's a progestin-only method. You just want to avoid if patient has thrombus because the body does see a higher dose of the progestin and can have a risk of thromboembolic disorders. So you can't put this in if a patient had a blood clot themselves. Family history, you can. It probably has a lot of potential for non-contraceptive use, but no indication as of yet that I'm aware of. Okay, it is 8:44. I have 5 minutes for questions. You can use the chat or I just want to check the chat and see if there's anything on there. Please use the chat or speak. Okay, so somebody just said true from before. Anybody have questions, thoughts? I'm sorry, it's throwing a lot of information at once. I tried to review both contraception and how pills work, but I tried to hit upon some common methods and why you might use them for non-contraceptive indication.
Dr. Brill, I have a
Brill,
question. Sorry.
Yes.
Sorry, I think I'll give the chance to Sammy. Was it Sammy? Anyone else wanted
it's
to
okay.
ask? Yeah.
Thank you, Suresh. So we have a lot of names. Like, do we have like memorize all these names or the trade names and the component in each one or not? Or there
Yes.
maybe like a poster or,
So, you know,
or there is a poster for IUDs and the component in each capsule. Like, for example, in asthma medication, we have like a poster and we have every like inhaler or device we use with this. If there is like a simple way to navigate our way through all these products?
So, you know, not that I'm aware of, but there is, I've heard you guys use Epocrates. Epocrates have have a nice summary of like OB-GYN medicines, and it's all in there. I think a lot of it is online too. There's also, I think Up to Date has a pretty nice list of pills, you know, brand name and then generic and what's in it. But I've used Epocrates. That's, you know, sometimes I just like, I get this brand, I'm like, what is this? And I'll just look it up in Epocrates. So that they have some nice charts, but it's probably findable online, I would think. I haven't ever seen a poster for IUDs. There's probably about 4 or 5, so it's not like so many. But there are about 4 or 5 different brands now of IUDs. Some last 3 years, some last 5 years. So that, but I think that's findable. But you're right, it's really confusing. I still and I feel like I don't know whose job it is to come up with the names of the brand names, but they're really like, I don't know who comes up with them, but they're really crazy names. If you look at them. Yeah.
Thank you.
Sarisha, did you have a question?
Yes, this may not be like totally contraception, but there are girls who approach us like if they want to postpone their period for a few days. Would you like put them on OCPs or would you go the progesterone route for?
You know what? It just depends. If it's just a one-time thing, you know, like I've had girls who've, let's say, gone on, I guess it's called the Hajj, like a pilgrimage, and they're not supposed to get their period when they're on a journey like that. So I've used just progesterone. I use a formulation of norethindrone called Adolescent, which is a 5 milligram progesterone. That will just push off a period by a couple of weeks. I also use it in my girls who are about to get married. Anyone who's worked with me, I have a number of girls who, you know, are in later teens or young adults and they get married, and I'll use the Adolescent to kind of push off their period and see if I can delay it after marriage. So just a one-time thing, I'll just use progesterone. If somebody really wants cycle control all the time, then, you know, going on a birth control pill makes more sense. And if they're on the pill already, I'll say, you know, just skip your placebo this month and you're going on a cruise, you don't want your period, just skip your placebo and go right to your new pack. So you have a lot of control with a lot of the medications. You have to be creative, but you can do it.
Okay, thank you.
I
And
call it intermediate to advanced pill taking.
and how many days do they have to start this before? Like
the Adolescent,
yes.
probably a week or two. Just make sure they tolerate it.
Okay, thank you so much, Dr. Brill.
Sure, great question. Okay, other questions, thoughts? No, that's good.
Thank you, Dr. Brill.
All right, I hope this was helpful. I think this ends my, I think 3 in a row for you guys. So I think this ends the adolescent block but so I've enjoyed speaking to you, and I know your chiefs will get me back for a few more talks over the rest of the year. So, and then, you know, y'all come one by one to St. Peter's and work with me later this year. So see you guys soon.
See you soon.
Okay. You're welcome. Be well.